Mhm. Welcome, welcome, welcome. Welcome back to another episode of the Red Pill versus the Blue Pill. My name is Dr. Delon Canterbury. I'm the founder of GeriatRx, as well as the Deprescribing Accelerator. So today's episode is sponsored by GeriatRx, as well as the Deprescribing Accelerator. So welcome back. Hope y'all are doing well. For the record, we'll be doing Red Pill versus Blue Pill every Thursday at 12 p.m. Eastern. And again, we're going to be discussing how you can unleash the power of deprescribing in advocating for our seniors in reducing harm. Reducing healthcare costs is always the goal, and helping advocate for our caregivers who are stuck in this matrix we call the healthcare system. And so I am Delon, aka Morpheus, aka the chief deprescriber, aka the drug whisperer. One of my friends just dubbed me. But I'm glad to be back. And so today's topic is discussing essentially the elephant in the room, right? How many seniors have to be put in harm's way for our health system to incentivize and prioritize deprescribing to be the standard of care? And of course, there are many avenues you can take, whether it's through, diet, exercise, lifestyle, but I believe there needs to be a multi-pronged approach to helping to get our seniors off of these damn pills. So I am Delon. I'm a board certified geriatric pharmacist and started geriatrics in 2020 with the sole frustration of what I saw in those community settings, in those retail settings, and felt there was a need for pharmacists to perfectly segue into senior care through our knowledge, through our advocacy. And so I'm on a mission. I'm on a complete mission to change the way we deliver care within our SNFs, our nursing homes, our long-term care facilities, our adult daycare centers, any senior care organization that's touching a senior patient has to has to keep in mind that the meds may be causing more harm than good. And that's just statistically proven since we have so many people on 5, 10, 15, 20, 25, 30, so many meds, right? They're on a lot of meds. And so my goal, vision, and calling is to educate as many uh, clinicians as possible to the world of deprescribing to help you understand how you can sustainably implement this. It's definitely not easy, but it is something we can do. And it's achievable since we have the data to back it up. And well, I just can't wait for CPT codes and Medicare and all these entities to take 20 years of lobbying and fall on deaf ears on how we can really provide more preventative services and value-based care. So I believe wholly that deprescribing is a key piece of value-based care and needs to be at the forefront of all care delivery models. And yes, I know it's difficult. I know that, guess what? We're not taught this mindset. I know this is going to sound like it may ruffle some feathers. I don't care. All right. Because I'm tired of seniors dying. I'm tired of my grandma, who was a statistic from an antipsychotic who had dementia. And I'm tired of seeing patients who, like her, were inappropriately prescribed a harmful med, all because no one cared. So I'm tired of that. I'm tired of this excuse of time, and I'm tired of putting the bucket onto other clinicians to fix the problem. I'm tired of it. I've seen too much of it. It's why I'm so driven to make sure that you know what the hell deprescribing is and how we can put this into all facets of patients, social workers, community health workers, ambassadors. There's a future where I foresee deprescribing pharmacy technicians. I see so much that we can do with this movement, and our titles shouldn't really matter. I believe that pharmacists are, of course, the drug experts, so they need to be quarterbacking this. But ultimately, the quarterback is the patient, right? That we're in this for the patient, not for our egos, not for our titles, not for our degrees, not for just this sense of, oh, the warm fuzzies because, I have a piece of paper and I could walk into a room and act like I know everything. We don't know everything. We don't know the worlds that people live. We don't know how to have empathy in our health system. Like we try to pretend like we do. And then you want to assume that everyone has equal access to care. So that's a whole nother gamut of issues. But let's talk first about just deprescribing. Okay. I love it. I love discussing it. I love empowering my clinicians and alum to be better advocates and ask the right questions, right? Are you on more than 5 or 7 meds? When was the last time you've considered stopping or working with your doctor to slowly wean you off of certain meds? What lifestyle changes have you considered for I don't know, pain management or your blood pressure, right? I feel like it's like when we look at guidelines, we're quick to say, all right, lifestyle modifications, 5 lines. And then you have like a whole segment on drug therapies. It's like we are not even prioritizing like the low cost, easier options. We're going straight to all right, what's the drug? What's the treatment? All right, boom. And then we don't even consider a timeline on when to stop these meds. So all I'm asking is, have you asked your loved one who's on 10 meds, like to their primary care provider, what can we do to safely get granny off of these meds, Louise, auntie, whatever. What can we do to consider getting her off of some of these things? Are they life sustaining, right? Are they vital for the patient's quality of life? And are they essential for them to live? Are we asking those questions? You see, you can't assume that patients and caregivers are suddenly now the experts of all the meds they're taking. Yes, there needs to be some ownership on what we're taking and putting into our bodies, but they barely even know who to ask or what to ask when they walk into that doctor's office. So it ends up being and everything's fine. We'll talk about this next month. And our silent generation cannot keep suffering in silence because they don't know how to ask or who to ask, or may not have a loved one who knows how to work the system or knows how to push back against whatever's being done. So why not have people who specialize in deprescribing help advocate? And that has been really my golden ticket to where I am today is inserting myself into these caregiver spaces to speaking nationally about this issue, talking about value-based care, talking about patient advocacy, talking about senior care, talking about how we're not talking about the elephant in the room, which is 80% of treatments are medication based, they're drug based. 80% of how we take care of someone in this country is some kind of pill. 80% of all therapy. So it's like we're just skipping to the end, right? We're not even trying anything to change because we are not built systemically to incentivize that. It's a newsflash, right? We don't think that we write off patients because it's like, they're obese. I don't believe they can actually, that you write them off with these labels, these microaggressions within our own medical communities and don't even give the patients a chance to like see what can be done safely or alternatively or even in combination with the pills, right? Like I'm not against meds. I'm against the medication mindset. I'm against this philosophy of having to overtreat every little thing, and frankly, once you have one diagnosis code on your health record, it's hard to get that bad boy off. And now you end up in a cycle of other issues and other diagnoses and other unnecessary, frivolously thrown at labs and draws. And just you end up spending on the back end of our healthcare system a lot of time and resources for an inefficient means of trying to help the patient because we're not really hitting the root cause issues, you know? So I got my geriatric pharmacy credential in 2017 only because, well, I had my grandma in mind for sure, but only because of what I saw at Walgreens. Only because I was a pharmacy manager and I was in a rural town of Henderson, North Carolina, and my God, there were so many drug errors and mistakes. And the primary care at one point was the urgent care because the town's doctor had actually just recently died, like right when I took over the store. So there was this confusion. People didn't know where to go. I mean, he was like an independent, beloved physician. So now everyone's basically going to urgent care for primary care issues. And so I'm seeing all types of crap. I'm seeing duplicate therapies, brand name generics. I'm seeing lisinopril and losartan, like crazy interactions, right? And then worse yet, I found that it was my senior patients, my black senior patients, my rural white senior patients, and Latino who came in with the worst issues, the worst social barriers, the worst cost barriers. Transportation was a very big issue. Having gas money just to come pick up the scripts was an issue. We weren't really delivering yet to people's homes because COVID hadn't hit. So when we're not talking about people's zip code dictating how long you're going to live, but we know that this is to be fact for decades from a public health standpoint, then we're literally just doing a little bit within that snapshot of time at the pharmacy counter. So I hated how trapped I felt and didn't like that I was playing the reactive game, with people's care. So that got me into the world of eventually, volunteering locally, getting involved with senior care groups, working with senior pharmacists. So shout out to Dr. Gina Upchurch and Dr. Marilyn Disco, as well as Shari. I hope y'all are doing well. But I ended up volunteering there and getting my hands dirty in this space, in this advocacy space, by serving on their formulary committee, and then start seeing, oh wow, there's so much more to this that I feel we're not addressing in our healthcare system, where we're depending on amazing groups like senior pharmacists. But why isn't that the standard of care for all of our seniors, right? You know, a social determinant questionnaire isn't the end all be all if you're not enacting the tools and resources to help people actively get a better way to healthily age. So that opened my eyes to this, despite what I saw already in the community setting. And worse yet, were the unspoken heroes, right? The unpaid heroes of all of our caregivers out there. They're caregivers who are doing all this work, who don't know who really to go to. They want to go to the doctor. They feel they're not heard. In fact, it's just very difficult for them to maneuver this without really at someone who has their back. So who better than someone who's been in the system, who understands most of the logistics, at least than a pharmacist or someone who navigates, like the patient access navigators, right? Nurses who are in the game, gerontologists, they know how this works. So why aren't more pharmacists doing this? There's like over 300,000 pharmacists in the US. I think what, maybe 1% are even geriatric trained. Yet this is the highest growing population in our country, and we have less and less geriatricians, less senior care providers. We have less beds in nursing homes. Do you guys understand that hospitals are literally converting their wards to makeshift nursing homes because of this housing crisis? How can you ask someone to take a pill if they don't have a place to live? Wait, I mean, you can't. So when we're talking about these med reviews, deprescribing, it can't just be done on the lens of what your med list is. You have to talk about the psychosocial, spiritual stuff. You got to talk about their patient goals. It needs to be patient centered. It needs to align with what they want to get out of this, And I couldn't do all that while I'm trying to fill these scripts and count by five and give flu shots and COVID shots and, you know, trying to handle PAs and handle angry people, and it burned me out. I got super depressed. I was angry. I was hating everything. I was hating life. I was hating you. I was hating you. I was hating everything. Do you know how it feels to hate everything every day as a career? And I'm not downplaying the role. I'm just saying I hated everything. I would say the few times that patients were appreciative or maybe brought me some food or showed some love and said, "Oh man, thank you for looking out." Like those are the patients. You get the warm fuzzies. You feel good about that, right? You love those moments. We live for those moments as clinicians. The little cards, the cakes that were made for your team. Like I love those people, right? Don't get me wrong, but the day to day, hell no, I hated that stuff. And it didn't need to be that way. I mean, who sacrifices their time 8 damn years, to getting an advanced degree, and then you end up hating it for the rest of your 40 years until you retire, and then you live for 5 and then you die. Screw that. Like, I'm not doing that anymore. I'm not doing that, and I'm not doing what's right for me spiritually and in alignment with what I've enjoyed doing for my clients, for my patients. So and I really want to pose to our health system, to our politicians, to our Fortune 10 companies who make billions screwing people over on insurance claims and all these vertical integrations and PBMs. You can name any bad guy you want. But really, is this how far we've come? Is this the best we have to offer? Is this life? You think I want to retire in this country? Seriously? You think I'm gonna get a social security check in 30, 40 years that's gonna help me sustain and age and live gracefully? Bro, no. I don't think Medicare is gonna exist in 2 decades, truthfully. I think it's gonna go bankrupt. It's already being slowly privatized. I mean, first of all, there's no power with CMS. It's the PBMs that control it. And so we're begging to negotiate costs for people that worked all their lives and now have to just nickel and dime whether they can eat or get their 90-day fill. So, yes, how many seniors have to die? How many? I'm asking how many have to die in order for us to wake up to what's around the corner? And I mean, it's already here, but it's happening. It's happening now. Like we cannot ignore the fact that we have so many people who don't have access to care. We have seniors who, unless you're like ultra wealthy, you're fine. I mean, at least you could still be screwed by our health system. Don't get me wrong, even if you're rich or poor. But like, how many have to die in order for us to change the way we deliver primary care? I do see we're starting to shift more to this medical home model and kind of have people, kind of just be outsourced or telehealth into the people's homes directly. It's going to take some time for us to get down packed and really move the needle on in terms of accessible care, especially in our rural communities, our rural health centers that took a thrashing during COVID. Um, Health systems are crippling too. That's the worst part. It's like they are losing money, and the ones who are making money are still maintaining that market share, and they're doing so by buying, 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 buying all the other smaller health systems to sustain themselves. I don't know what that means in the long term. I do know that there's going to be a monopolization of healthcare, and we're going to pretend like there's a choice. There is no choice with your insurer. It's you can choose what you want, but you're going to end up sticking to really the same one or two players in the next few years. So I again ask because I don't want this silent generation to just phase away as if they're not valued. I mean, I love the geriatric space because of the people. Truthfully, these seniors are awesome. There's so many stories. There's so many takeaways. I mean, the just the the wealth of knowledge they have, and you can really judge a country by how you treat your seniors and how you treat your vets. Let's be real. We haven't even talked about senior vets. Um, Hey, Daryl. Looks like Daryl is tuning in, and he shared some comments. I'm going to put that on the screen real quick. But Daryl thinks it would help immensely if pharmacists have provider status, because unlike now, it would recognize that we know what we're doing. And I could be wrong about this, but I don't think that we would be so far behind the provider eight ball if pharmacy practitioners had actually fought to stay in existence after leaving federal service along with PAs and NPs. Okay, I kind of agree with that. Uh, Instead of hiding behind the nearest counter at CVS way back when. Most of my younger colleagues have no idea such even existed once upon a time. And then it fades out. You know, Daryl, you're right, man. We haven't been the best at fighting for our profession. We're kind of the we don't want to rock the boat type. I hate to stereotype pharmacists. Of course, clearly not all of us are like that, but we are very much, what do the guidelines say? Are we allowed to do that? Oh, no, we are our own bosses. All right, we are our own experts, and I agree with you, man. We don't we're not the most, and I can't lie. I'm complacent too. You think I was involved in all these associations and voting and stuff for pharmacy when I was working in the field? I wasn't involved. I wasn't even that involved in pharmacy school. The only thing I cared about in pharmacy school was SNAFA, which was helping hopefully with reaching marginalized communities and bridging some of those gaps in our care. So I'm with you on that, man. I think there needs to be a change in our pride for what we've achieved and accomplished. I don't think we own our greatness, um, and I think sometimes we shy away. We shy away from confrontation. Period. Of course, not all of us, but you know, if that being the nature of what I've seen and witnessed from my experiences, then it's no surprise we're where we are. It's no surprise our profession's owned by insurers and a product based delivery. Like we're attached to a product. No one thinks as a pharmacist as a consultant. They think of us as we deliver pills to you, and that's it. Or we may check an order, and that's it. That's a product. We're not seen as people who lead grant initiatives to meet community needs. We're not seen as dementia advocates who can specialize in helping reduce OTCs that cause harm in dementia patients. We're not even seen as opioid deprescribers, yet we know how to do all these things. So why aren't we marketing that? Why aren't we selling that? Why aren't we leveraging that? We're not even seen as consultants. We're naturally public health specialists just from what we do in retail. Like you have to know social worker, psychology, got to motivate. We're doing all these little things to try to help people. Not the best, but we're doing it. Mom and pop pharmacies are trying to deliver advanced care models. They're doing, glucose monitoring with remote patient monitoring. There's so much potential for us. And like Daryl mentioned, I feel politically we don't have as much backing as, say, our nurse lobbying power, which is the strongest anyway, and our physician AMA lobbying. And don't get me started on the pharma lobbying power, and I mean the association that represents the other big pharma players. So yes, politically, there's a fragmented system that makes it difficult for us to enact some of these changes. Sure. However, I still see significant results from deprescribing within our own health system, but they're all in little silos. They're all in little pockets of health systems here and health systems there. It's like, oh, great, we did it. So why aren't we doing it everywhere? That is why I created the deprescribing accelerator. It's to get us ahead of the game, or at least up to where others are, because we're not leading the pack in deprescribing. We're getting there. But the job is for us to see that it's going to take a multi multi-pronged approach. There needs to be a policy change to advocate for seniors. There needs to be more funding for the key stakeholders that incentivizes when it comes to our nursing homes, our SNFs. There needs to be a change in policy, period. There needs to be incentive from the ground up. So community members need to know, like community advocates, patient care navigators, gerontologists. These are the people who touch seniors. So if they don't even know that there's a pharmacist that they can talk to help them get off this, and we know every senior's on damn near 10, 20 meds, then we're not going to move the needle. We're not going to move the needle. So you gotta embrace community strategic partnerships. There has to be a concerted effort from our local government and policy. There needs to be more funding towards our National Institute on Aging and the NIH. There needs to be better management of what's trickled down to some of these lower areas of offices on aging. I always get the acronym wrong. Area agencies on aging, whatever. But I'm remiss to find out that they can't even control half the budget they get. And I'm thinking, hey, this must be a flat fee for all the AAAs. But no, if I'm in the RDU, I have great access to AAAs, which are the area offices of the agency and aging. If I'm in the mountains or Wilmington, it's tough. It's a tougher world for our seniors. So we don't have uniformity. We have limited access in certain remote settings. And frankly, our pharmacists are not awake to our intrinsic ability to help people get off of pills that they don't need. The tools we employ are accessible online. Everything is online. This isn't rocket science. It's literally, are you on more than 5 or 7 meds? Are you willing to consider changing anything in your life to get off some of these meds? Are you aware that there's a way to get off? Do you know that some of these medications have a timeline? Why are you on this omeprazole for the last 30 years? Why are you on this antipsychotic in a nursing home without bipolar or schizophrenia? Why are you taking Benadryl to sleep if you have dementia? Why are you taking this ibuprofen long term if you have chronic heart failure? A little bit of pharmacist knowledge, but a lot of impact when it's embedded into policy and procedures. I don't think it's that hard. In fact, it's not. Don't get me wrong. In terms of political agendas, it's hard as hell, sure. But in terms of practicality and just starting small and scaling, it can be done. It is being done. It is being done. It's being done all over the world. You see, we don't know this. This is why I have to make sure you're aware that Australia is doing this better than us. Canada is doing this better than us. The European Deprescribing network doing it better than us. They've been doing it. Stop Start came from Ireland, which is an acronym for screening tool for older patients for inappropriate meds. All readily available. Do you really think primary care providers even use the beers list? And I'm not blaming them. Don't get me wrong. This is not a blame game. This is a system issue. They're not taught this in medical school. Shoot, I wasn't taught this in pharmacy school. I didn't even learn this from my board certified geriatric credential. I learned this, investigate and research this, and put it into practice with my N of one self. Hey, Mariko. Hope you're doing well. Thanks for tuning in. Um, so again, I ask, how many seniors have to die? 750 seniors are hospitalized every day in the US due to medication adverse events. Have you ever had an ER medical bill sent to your home? Do you know how much that costs? It happened to my mom. I've seen that bill. It's happened to my dad. We've seen that bill. They have Medicare. It's still tens of thousands of dollars. So do we care? That's what I'm trying to challenge. I'm challenging this mindset that we need to just continue with what our health system's letting us do. I'm not doing that. I'm never going to do that. I did it for a long enough time to know that my spirit died and I cannot live this way. So if we know 750 seniors are hospitalized every day in this country, how are you changing the way you function in your day to day to reduce that number? In your world, how are we advocating for our patients? How are we empowering them? How are we educating them? How are we empowering better prescribing habits? How are we teaching the new generation of NPs, of PAs, and prescribers? How are we teaching them that there needs to be a different approach on how we treat? How are we changing system-wide policy to incentivize this so that we don't have to come out with these weird, not even weird, but just out of the wall, you know, approaches versus just making it policy? Is there any insurance plan that wants people off of medications? Can y'all raise your hand? Can someone let me know? Is there any insurance plan that believes less is more? Any at all? Please, for the love of God, someone tell me. Is there anyone in this country? Is there anyone that sees the value in deprescribing on a national level? The only reason my grandmother Mildred lived to see 90 was because a Rite Aid pharmacist in Atlanta discovered that she was on ziprasidone and had dementia, and it worsened all of her symptoms. And my parents had no clue why she was declining. And that's something I'm never going to forget in my career and in who I am. So if it happened to me, it's happening now. It's happening every day. In fact, it's worsening. There's been a 21% increase in the use of antipsychotics within our nursing homes in the last 2 decades. And COVID has not helped. There needs to be a patient centered approach to managing some of these neuropsych conditions when dealing with some of our dementia patients. Doesn't always have to be a pill or Haldol or lorazepam. It could be music therapy. It could be pet therapy. It could be, shoot, rotating them on their bed. I don't know. It could be just talking to someone. It could be redirecting. Uh, I agree that there needs to be a better training and education around what we can do to deprescribe. Because I get it, there aren't exactly clear cut, cookie perfect guidelines. It's a fine art. Everyone's going to be individualized. However, the mindset still remains on what can we do to get you off these damn pills safely with the supervision of your doctor. Of course, we're not just having you getting off drugs for the fun of it. Um, so again, I had the amazing pleasure to meet some really cool caregivers and people moving mountains in the geriatric space at last week's luncheon I attended with the North Carolina Coalition on Aging. Listened to Dr. Tracy Gendron, who gave a brilliant speech on ageism unmasked and how we can try to kind of get rid of some of the subtleties of ageism within our own, on the provider end too, as well as the society's lens. We value youth, we value sexiness, we value energy. We don't value people who may be just older. Shouldn't keep you from being at the table. What does that matter? Shouldn't matter. So because of that, there's all types of subtle preconceived presumptions of people in that space, and that ain't right. So if we're coming in treating patients this way and not knowing our own implicit bias, how are we going to move the needle? How are we going to truly, truly make that impact? So I hope today um, helped shed some light to what I feel a lot of us are doing across the world, but also I want to highlight those who are doing this in their own little world, within their own health system, within our country. I'm not bashing the entire, maybe I am bashing the whole health system. I don't know. I'm tired of talking about this, but I love talking about it because I'm just tired of the uphill slugfest that we're against. But it starts with educating, and it starts with communicating that there is a way. And it starts first and foremost with trust. You gotta have someone who trusts you, who's in your corner, who's got your back, who's doesn't want more seniors to die unnecessarily and write them off as side effects or unknown cause or whatever you want to say. I talk to these ER physicians all day. I talk to them all day, and they are seeing polypharmacy as the admitting reason why they are bottoming out on their blood pressures or why they fell and now they have an internal bleed or whatever, because they're still taking aspirin and Plavix and an NSAID because no one cared to talk to them about it. These are all preventable. And if we know this is costing our healthcare system close to $528 billion a year that we are all paying for, wouldn't we want to incentivize reducing that cost? CMS, are you listening? DHHS, are you listening? AMA, who makes the CPT codes, are you listening? Are y'all listening? Okay, I hope so. And I'll say it again. So, love y'all. Appreciate you tuning in to the Red Pill versus Blue Pill. Of course, I'll be back next week, next Thursday, 12 p.m. Eastern. Um, really appreciate y'all tuning in. Thanks for the support and love. Oh, hey, Sandra. Thank you. Sandra said, I made a move that is so impactful that it is commendable. This conversation is an important step in the right direction. Yes, 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 it is. I appreciate it, man. It really is. It's not for me. It's, it's for our aging population. Um, but thank you. I love what I'm doing, and if I see a way that we can do it sustainably and you can monetize it, why not teach people how to do that? That's the goal here. That's the fun behind all of this. So, got much love for y'all. Appreciate everyone's thoughts. Daryl, I loved your contribution today on the lack of advocacy I feel we may have had with as pharmacy practitioners. I didn't even know that much that occurred back then. I thought that was a more recent thing, so I learned something from that today too. Um, but yeah, hope this was awesome for y'all as much as it was for me. I'll be back next Thursday at 12 for more Red Pill versus Blue Pill. We're changing the world. We're changing the way we approach aging. And we're going to change prescribing habits with this. So I won't stop until this is in every nursing home. This is in every LTC. And I don't mean just checklist with Medicare. I'm not talking about F tags. I'm talking about a whole different approach on how we do this. Because guess what? Other people are already doing it, and they're doing it right. Y'all be good. I'll see y'all next time. All right. Take care.